This session on neuropsychology and the developing brain. I'd like to start by introducing my co-chair, Simona Cappelletti, who I'd like to thank for putting together this proposal for this important symposium. So Dr. Cappelletti is a neuropsychologist in the epilepsy unit of Bambino Gesù Hospital here in Rome, and she has been working in the field of epilepsy for 2 decades. She assesses children who are candidates for epilepsy surgery or who have a variety of other epileptic syndromes and is interested in studying their outcomes. She is also coordinator of the Italian study group on neuropsychology and cognitive neurology of the Italian League Against Epilepsy. So, Simona.
Thank you, Prof. Good afternoon, everyone. Thank you for joining us. It's a pleasure to welcome you to 15th European Epilepsy Congress at the session Neuropsychology and Epilepsy in Developing Brain. We have an exciting program lineup, and over the next 4 presentations, you will hear from top researchers and experts about the latest breakthroughs in diagnostic and the care of children with epilepsy. Each presentation will have an interaction final part where you can ask a question and express interest in specific topics or make comments. I encourage you all to participate and take this opportunity to network with international colleagues. Together we can push the boundaries of epilepsy research and improve patient outcome. First, I don't think I need to explain why I invited Professor Mary Lou Smith, who deals with developmental age epilepsy, having benefits over the years from her literature and studies on theories related to evolution of neuropsychological function and how they are affected by epileptogenesis. Mary Lou Smith is Professor Emeritus at the University of Toronto and a scientist in the Neuroscience and Mental Health Program at the Hospital for Sick Children. She has conducted research on cognitive, behavioral, and quality of life outcomes after epilepsy surgery in children. She is active in the education and advocacy in epilepsy and is a member of several task forces of the ILEA and chair of the ILEA Neuropsychology Task Force. Today, she will introduce us to pediatric neuropsychology issues in complex epilepsy. Thank you, Prof.
Thank you for that kind introduction. So I am first of all, I have no disclosures or conflicts of interest to declare. And I'm going to talk about some issues that relate to the concepts of plasticity, recovery of function, and windows of opportunity for children with epilepsy. And in particular, I'll speak about these in the context of treatment, specifically in relation to surgery. So let's start off by asking, what is plasticity? It's the brain's natural response to experience, how we adapt, learn, and acquire skills. It is also an adaptation to injury. It's an intrinsic property of the brain, and we have to remind ourselves that it is not exclusive only to the young brain. It exists at any age. So as you're sitting here listening to me, I'm changing your brain as a result of that experience. Plasticity can be structural or functional in nature. So if we look at this diagram of neuroplasticity in the developing brain, we can see that there are a number of aspects. There's the developmental aspect, including the normal processes that lay down the development of the brain. And if these may be impaired in a number of neurodevelopmental disorders, many of which have epilepsy as a feature. We can also consider neuroplasticity to be adaptive in response to experiences, as I said. It can be reactive to injury or deprivation. And in this diagram, they've included hemispherectomy as an example of an injury, but we can also extend that to other types of resective surgeries in children. There can be excessive or destabilizing influences in neuroplasticity, and again, because we're interested in epilepsy, we can see that these include epileptogenesis. And finally, some of the vulnerabilities of the central nervous system, including anoxia or the epileptic encephalopathies. So often the young brain is thought to be more plastic than the older brain, and this has led to the idea that in the field of epilepsy surgery, earlier should be better than later, due to this potential plasticity at the structural level, or also when we think about it at the functional level, we can think that it might be important because the cognitive and behavioral comorbidities that are associated with epilepsy may be less entrenched in the earlier child than at later periods of development. But we have to consider that early brain dysfunction is not always better than later brain dysfunction, and we have to keep in mind that there are important developmental considerations across the lifespan of the child that can play into outcomes. So animal models show that timing of injury is key. So this is a table that's adapted from some work of Brian Kolb and his colleagues based on lesions in rats at different periods of the development of the brain. And here you can see that there are sort of equivalents in terms of human development. And what you can see is that they have isolated that there are two periods of times in which damage is particularly negative in terms of outcomes. So at the P1 to P6 level in the rat, which corresponds to about the last trimester of pregnancy, the stage of brain development at that time, can lead to severe functional impairments. And then lesions slightly later in rat development or in human development can lead also to only partial functional recovery. Now, this is an interesting diagram from this article that was published a couple of years ago on children and adolescents who had undergone hemispherotomy. And this diagram shows various types of pathologies to the brain, starting at the time of their instantiation from the first trimester, such as focal cortical dysplasia or hemimegalencephaly, and continue on to injuries or pathologies that occur later in development. And what you can see is that in their cohort, 82% of their patients were in the severely impaired group if they'd had hemimegalencephaly or focal cortical dysplasia. And in other pathologies, the outcomes were less significant, but nonetheless, a considerable proportion of their sample had these severe impairments. This diagram is a composite of children who had a variety of early focal brain insults, and outcomes in this study were measured at the ages of 12 to 14 years. And the diagrams show different types of cognitive skills, language, visual, spatial, processing speed, etc. And pretty well what you can see is this consistent pattern where those children who suffered their injuries congenitally or in the perinatal phase of development or in infancy were less better off as adolescents in terms of these cognitive skills than children who had their injuries sustained in the preschool, middle child, or later childhood phase. And this is not necessarily what you predict if you think that an early brain injury is better than a later brain injury. We also have to acknowledge that the impairments that are seen after early lesions differ from those that appear with later lesions, so we can't extrapolate directly from the literature on adults. We also have to acknowledge that after early damage, impairments may not occur immediately, but may emerge later in development. So I always give the example when I'm talking to parents, for example, if your child had a brain injury at 2 months of age, you don't know the impact of that on reading or executive function until much, much later on in development. And we also have to acknowledge that the trajectories of development may differ across skills. So here are some hypothetical examples of the consequences of injury on development. I won't go into these in detail, but you can see that there's a number of patterns of possible outcomes that can occur when you have a prenatal injury or when you have a postnatal injury of some type. So some may show rest in development, some show loss and recovery, and so on. But any number of patterns of recovery may be apparent. So a number of years ago, Maureen Dennis published a heuristic for investigating the possible effects of early injury. And she defined 3 degrees of skill maturation. So a skill may be emerging, it's not yet functional, or it's very preliminary. It may be developing, it may be a skill that's partially acquired but still has some maturation to happen, or it may be a skill that's already fully acquired. So if you think of emerging skills, so if you have a brain injury very early in life, then that may affect the onset of the skill, so it may be normal, or there may be a delay in onset. Or the order of the emergence of that skill could be garbled or different in relation to the emergence of other skills. If we look at a developing skill somewhat later in childhood, we could see that the rate of development may show a lag. There may be a detour or a differentiation in the type of strategies that the child uses to capitalize on that particular skill, or there may be a shortfall in the mastery of the skill. And if the injury occurs even later in development, then we can think about whether or not for a skill that's already been developed, is the individual going to lose their control of the ability to use that that skill, or is there going to be a permanent deficit? So there are a number of implications of this heuristic for epilepsy. So when we think about the type of pathology and the timing of the onset of that pathology, is it in utero? Is it later in development? We have to think about the timing of the onset of the seizures, because that might be an additional insult to either a normal brain or a brain that's already pathological. Think about how long the child has had seizures, and then if we consider surgery, we have to think about the timing of the surgery and the impact of that surgery on seizure control. So I was able to only find one direct test of this heuristic in the epilepsy literature, and this was a study done a number of years ago by Gonzalez. And she and her colleagues investigated 2 groups of children, one who had early onset epilepsy between the ages of 3 to 5, and the others had onset somewhat later between the ages of 6 to 8. And they defined a number of cognitive skills ranging from language skills, associative memory, aspects of visual spatial skills, deductive reasoning, and working memory span. And they defined whether, using the tasks that they had selected, whether those skills were in a period of stable development, shown in orange, or were they in a critical period of development, just starting or to develop. And they made a number of hypotheses. They thought that the skills that were in a critical but stable developmental phase would be impaired, and that differences related to the age of onset, the early versus the later group, were expected for skills where one group was in the critical stage, but the other group was in a stable developmental stage. And these tasks included visual spatial processing, phonological processing, and deductive reasoning. And they finally predicted that there would be no differences related to age of onset for skills that were classified as critical or stable in both groups. And in their study, they included measures of receptive vocabulary, associative memory, and auditory span. So this is a rather complicated diagram of their results, so I'll just summarize them here. They found no differences for skills that were in the same, no age differences for skills that were in the same stage of development. So if it was a stable skill for young and for older children, there were no differences. And if it was a skill that was in the critical phase, they found no differences as well. In general, they found poor outcome for skills that were in this critical phase of development. Those that were already stable, those skills seemed to be more resilient to the onset of epilepsy. And the other side of the coin is that those that were critical were more vulnerable. So this is perhaps a phenomenon or a concept that we should think about when we are trying to develop this notion of windows of opportunity to optimize development in children, and thinking about when should be the optimal time for instituting treatments. Keep in mind that plasticity can be a good thing, but it can also be a bad thing. So we know, again, through the animal literature, that early lesions result in the development of new pathways in the brain, and that can coincide with the emergence of adaptive behaviors, but it may sometimes cause aberrant or maladaptive behaviors as well. And in the human literature, we have the effect called the crowding effect, which is an example of this. So we know that the reorganization of language after early left hemisphere lesions can result in the shift of language centers from the left hemisphere to the right hemisphere, which is good for the development of language, but that can lead to a negative impact on visual spatial functions. So here's some work done by myself and my colleagues on children who have left hemisphere seizure foci, and we classified those into those who have typical language development, so language is still represented in the left hemisphere, and those children with atypical language, so they have right hemisphere or bilateral speech representation. And these are the results for the two groups. The typical language is the white bars, the atypical are the gray bars. And first of all, we can see that the children who have atypical language representation, although the language shifted, nonetheless, that had a negative effect on their naming abilities. Their other aspects of their language were not significantly different from those with typical language. When we look at the impact on visual spatial functioning, now we see this evidence for this crowding effect, where those children who had atypical language representation performed more poorly than those with typical representation across all the three tasks that we used. Now, perhaps most of the research on language plasticity in children has been done in the context of hemispherectomy. So the idea is that if a child has a left hemispherectomy at an early age, it gives the opportunity for the language to shift. And I'll draw your attention to this interesting study, which was a systematic review, and they were able to identify across studies over 200 children who had hemispherectomy and had language outcomes that were measured in standardized tests. And the dark green bars show the results for children who had left hemispherectomy, and the lighter green are those children with right hemispherectomy. And again, the children with left hemispherectomy did show language development, but you can see that their scores are below the norms expected for their age. So 0 represents the typical performance for a child of that age. And these are Z scores, so bars to the left represent performance less than the mean. And what's interesting is that there are not many differences between children who've undergone left hemispherectomy and those who've undergone right hemispherectomy. And we know that early in age, both hemispheres do indeed participate in language systems. Another interesting finding from this study was their examination of correlations between performance on language tests and age at seizure onset and age at surgery, both of which are variables that are often considered in the plasticity literature. NS means non-significant, so when they looked at all of the pathologies that were represented, they did not find any relationship with either the age at seizure onset or age at surgery. Except for the vascular group, where children who had their seizure onset later in life had better performance on receptive vocabulary. And for expressive vocabulary, it was only a relationship in the children who had right hemispherectomies for the combined group or the Rasmussen's encephalitis. Again, they found that older age at surgery represented better performance on these variables, not younger age at surgery, which I'm sure has to do with the nature of the underlying pathologies, the nature and the timing of the underlying pathologies. So when we look at more focal resections, we can use this diagram here to think about what might change. So we know if there's an area, let's say this is a child with left hemisphere dysfunction, and our outcome of interest is verbal memory, we can see that in this case, the verbal memory centers are impacted negatively by the epileptogenic focus, and this child before surgery has poor memory, and we expect that to be unchanged after surgery. We might expect improvements in this case where the influence of the seizures extends beyond the actual area of the focus, so functions that are usually represented in these other areas of the brain might improve after surgery with that reduction in negative seizure influence. And finally, we would get a decline if the memory centers were still functional and they were removed in surgery. So here's an interesting study that compared children and adults with left temporal lobe resections, and you can see that after 3 months after surgery, there was a decline in both groups. However, we get a different perspective when we look at a slightly longer time period, now 1 year after surgery, where both show some improvement, but the improvement is much greater in the children than it is in the adults, and in fact, the children are back at their preoperative baseline. And what's interesting is that most of the outcome literature on resections of this type does look at 1 year after surgery, and in most cases, there is an improvement or not a difference from baseline. So when we're looking for positive effects of surgery, it's important to take a longer point of view, and this was demonstrated nicely in this study by Carolyn Skiro, who followed children for up to 8 years after surgery. These are children who'd undergone temporal lobe resections and found that it was only 6 years or later in which you actually see substantive increases in IQ. So in a study that my colleagues and I did looking at long-term outcomes after surgery, we found a somewhat similar finding. So when we compared baseline with about a 7-year follow-up, we see that there are advantages in a number of indices of intelligence. However, what I want to point out to you is that these increases in the seizure-free group, which is shown in blue, are quite modest when you compare them with the baseline. And the significant difference only emerges when you compare them with those individuals who continued to have seizures. And so you see this widening of the gap. So the advantage of surgery is not so much, in this study, is not so much an improvement, but it's in maintaining the status quo as opposed to further decline. This was illustrated very elegantly in a recent publication by Maria Eriksson, and she will be presenting on this study in the Neuropsychology platform session tomorrow, and I really urge you to go because it's an amazing study where they had hundreds of children who had multiple assessments. Many of them had multiple assessments before and after surgery. And what you can see here is that the green are those children who became seizure-free. The orange are the children who did not become seizure-free. And you can see this tendency to decline in IQ scores prior to surgery, and then again, in the long term after surgery, you get this rebound. And on the right, we see the difference between those who became seizure-free and were off their anti-seizure medication, shown in green, and those who are still on their anti-seizure medications in yellow. So I just want to end by reminding you that we have to be cognizant that there are other variables, some intrinsic to the person, some extrinsic, some environmental variables that also influence both normal and abnormal brain development and function. And this is a group of variables that was culled from the animal literature, but you can see also that in this very eloquent model of neuropsychological formulation in children with epilepsy, that there is now a lot of evidence that shows that there are a number of family and environmental variables that can impinge on the child's neuropsychological development, and we have to keep those in mind as well. So just to remind you that plasticity and recovery are complex constructs. There are many possible windows of opportunity for certain skills that are probably related to the underlying pathology. Plasticity may not always yield universally positive outcomes, and it's very, very important for us to examine in the long term the developmental trajectories of children. Thank you.
We have some minutes for question.
Okay. I used rather a lot of my time, so I'll turn the platform over to Anna.
Okay. Okay, I had the opportunity to follow Anna Lopez during the coordination of the Epicare Neuropsychology group and noticed the similarity with our approach, a hospital approach, and on severe epilepsy cases. Over the last years, patients admitted to hospital have changed, becoming more severe with an early diagnosis, but very complex, with the need for minimal improvement due to new therapeutic approaches. This is a general unmet need. Neurologists ask us how to assess or what tools to use in the case of severe or profound disability. I believe that as a psychologist, we may have many tasks or approaches to evidence some changes. We know how to observe and follow mental growth. To enhance our understanding of long-term development in epilepsy, could it be useful to have standardized scale choice by mental level? Or maybe use easy and isolated tasks to measure motor and language gain simply and the same for every patient with severe disability? Anna Lopez Sala is a clinical neuropsychologist in the epilepsy unit of the San Joan de Déu Hospital in Barcelona. She assesses children who are candidates for surgery and monitors their outcome since 2003. Her main objective is to improve the quality of life of these children from a triple perspective: family, school, and child. She is co-leader of the Pediatric Neuropsychology Group at the European Reference Network, Epicare, and now she will present the assessment of severely impaired patients in rare epilepsy syndrome. Thank you, Anna.
Okay. It's a pleasure to be here and sharing this table with my colleagues, Colin, Cynthia, Simona, and Marilu. So I've been asked to talk about, as Simona said, how to assess severely impaired patients in rare epilepsy syndrome from a clinical point of view. So, as she said, I'm working in the San Joan de Déu Hospital in Barcelona. This hospital is devoted exclusively to child and maternal care. And I'm working in the epilepsy unit. And this epilepsy unit is a member of the International Network for Rare and Complex Epilepsy, Epicare. And in the hospital, in our unit, we have 3 beds. So more or less, we can assess 180 kids per year. Of these kids, along all the years that the unit is working, from 2005 to 2022, almost 500 kids had got surgery, and of these, almost 75% are in angle 1-2, so the outcome is pretty good. But today, I'm here to talk about the assessment of severely impaired children, and I have to say that is a really big challenge for us, for neuropsychologists. As most of you know, to assess some of these kids, some of the kids that are in the unit is very easy, like a piece, like a puzzle of 4 pieces. But these very severely kids are very complex, and it's very difficult. But we know that some of them, they have no language, and we have to assess these kids. Some of them, they do not communicate. Some of them have a very attention span very, very short. Plus, some of them, they have autistic spectrum disorder features. Plus, we know that all these kids, they fluctuate a lot, their performance over time, and indeed in the same session. Plus, our tests, they have floor effects, and the last but not the least, the collaboration. No? Some of them, they don't want to collaborate. And some of them, we have to be very patient. And with some of them, we have to make a deal. And if they collaborate, they end up getting like some present. Like, for example, with the kid, we make a deal with him with just a noodles, he wanted that noodles, and if he collaborate, he ended up collaborating, so we gave him the noodles. So, in this context, usually our doctors, our medical team, ask us to get the neuropsychological profile of these kids, and they wanted to have it before surgery and to know or to give them information after surgery if there is any change. So this is our challenge, to give that answer. And in our point of view, the goal of the neuropsychological assessment is provide a neuropsychological profile to see if we can correlate the neuropsychological findings with the epileptogenic zone hypothesis. Of course, to have a reference for next follow-ups and to monitor the progress. I'm sorry. Okay. Okay. And this neuropsychological profile is composed by different information that neurologists provide, like the basic ones, like reflexes, sensory systems, and all the motor development. And the top of the pyramid, it corresponds to neuropsychologists. And in the top of this pyramid, usually there is all the cognitive aspects that we have to assess. And our assessment has to be a comprehensive approach, which means that we have to get information from family through interview, anamnesis, or questionnaires, whatever, plus our clinical observation of these kids, plus, if it's possible, from psychometric tests, and plus the school report or questionnaires from the school. And in these cases, we have a lot of information from the nurses team. Like many times before we start assessing the kids, we talk with the nurses and they explain us more or less how is the kid, how is he interacting with the parents, and so on. So it's very important, this comprehensive approach of always when we just do a neuropsychological assessment, but in this case it's much more. So which domains do we assess to get the neuropsychological profile? Like always, IQ, that in these cases is below 50, most of them, language, memory, visual-motor integration abilities, executive function, academic skills, activities of daily living, very important with these kids, and all related to behavior and emotions. And we don't have to forget like the family context. We know that some families, they stimulate a lot their kids, and they go to therapy, they go swimming, they go horsing, many activities. And some other families, they do nothing with the kid. Most of them just TV and phones. Plus, we have to take into account the surroundings. Some families, they live in towns, so the kid can just walk around and, like in a natural surrounding. And some others, they live in an apartment in a city. Plus, the personal events of these kids. Some of them, they are maybe adopted, like many personal things. So let's see what we do with these kids to try to assess. Okay, IQ, as I said, most of them below 50, and most of the cases we just try to do like matrix reasoning, like the very basic levels of this kind of test. Of course, for this, the kid has to know how to point, if they understand the test. This is the maximum we can do, and many batteries have this basic reasoning matrix. For the language, not all of them have language, but a lot of them can communicate without language. But we know the different stages of this to get to developmental steps for language. And plus, here in this nice paper, they have a lot of small questionnaires to assess specific aspects of language, but we know these kind of stages, different stages, so we can describe in which level is that kid. The Vineland, for example, this is like the Vineland test. You know that it's like a questionnaire that we do with the parents, and here is the expressive part of this test. And if this kid, for example, he ended up with a raw score of 9 points, as you can see here. Okay, and after the surgery, he improved a lot, getting a raw score of 17. So we can kind of measure the improvement of this kid. Plus, we have all the naming tests, like Boston or any battery have like a naming test, and we can, of course, have like a summary of a sum of the raw scores, plus the receptive language test, like many, that you give a name, a word, and the kid has to point the right picture, or maybe like the fluency test, like words per minute, no? How many animals can you tell me in 1 minute? So these are language. Another domain is memory. It's a hard one, okay? I have no idea how to assess memory in these kids, so if somebody uses something, please, we can talk later. Memory, as you know, it needs a lot of different aspects like attention, learning, memory, and it's pretty complex with these kids. Visomotor integration abilities. We have the BIRI that most of you know. We have the blocks that Wipsy has, the Bailey has, and all this. So we can check how do they do this kind of pictures in a developmental way. And these are some examples that they can improve a lot. And we know, for example, here, the triangle, he couldn't do the triangle here, and after 6 months, he did it pretty well. And again, here, for example, the 3-line intersection, here you note the change. Okay, executive functions, a hard one, because the basic executive function is to be alert, in alerta, in like attention, vigilance, and all. And this is many of these kids, they have no attention at all. So, and this is very interfering all the other domains that we want to assess. So it's a hard one, but anyway, if the kid can, we can do some like digit span, and in this moment, I have to mention the EpiTrack Junior that most of you know. But at least the kid has to know number 1 and 2, and plus they have to know, you can see here many other things that the kids have to know to be able to do the EpiTrack Junior. And it's only 6 subtests, very easy and very short to administer. But the level of the kid has to be a little bit high, because if not, it's impossible. These are the other subtests of the EpiTrack. And as I told you, the academic skills is another domain that we usually assess about literacy and numeracy. Some of these kids, even though they're very disabled, in school they can teach them at least like some letters, some numbers. This is very, very low level, but it's something that a lot of them, they try. And all these domains, we use a test that already exists, as I told you, that the Bailey, for example, as you know, is a battery that goes from 1 month to 42 months old. And we use this material, but we use it out of the norms. So we just use the raw scores, and so we can just track all the evolution of these kids. Plus the WIPSI, as you know, is from 2.5 and 7 years. And again, we use the same material, but without using the standard scores. Another aspect that we have to assess with these kids, it's very important, are the activities of daily living, as you can imagine. In average kids, usually we don't ask so much about these activities, because normal kids, they do for themselves. But in this case, in these children, they are very compromised, all these activities. And we have to ask for each one, how are they doing? And the last aspect, but not the least, it's very important, it's behavior. With these kids, most of them, they have problems with behavior. And in this paper, for example, they defined some domains that we have to ask. And because we know that some of them are very impulsive and they can just kick or scream or hit others. This is disruptive behavior. Some others, they have a lot of repetitive movements, and they can repeat like hours or a lot of time. Some of them, they have communication disturbances, like echolalia. Some of them are very anxiety, problems relating to others, kids, and we have to just take notes about all these kind of behaviors. And from all this information, we can just have some diagrams, and we have to interpret these results. Which does it mean? That we should forget the standard scores, and we should use raw scores. And for each domain already assessed with each kid, we have to imagine, it's not, if you can draw it, you can see it, if not, just imagine the evolution of these domains for each kid. And for example, when we talk about deterioration, cognitive decline, or regression, it means that the raw scores go down, decrease. This is really a regression. But we have to see raw scores, not standard scores. This would be like an example of this. Another trajectory would be stagnation, which means that the kid doesn't improve but doesn't decline. It's always the same over time. Another profile would be slow development. In this case, as you see, the kid is improving, but is always far away from the normal development. And the last trajectory would be like a real improvement, a clear improvement in raw scores, and it's getting closer to the normal or average kids. So, new approaches, what would we like, no, Simona, with this, to assess all these kids? I think we need a normative data for children with intellectual disabilities. As far as I know, we don't have this. I know that some countries have special editions, no, of existing batteries, no, like bigger material or different, adapted to these kids. Maybe design a new battery for this population would be like a cool thing. And something that is already going on is a comprehensive questionnaire for parents, for this population. And related to this last sentence, there is the Become survey that is a 20 minutes online survey that it's very cool because includes all these areas that we have been talking about, like alertness, cognition, executive function, language and communication, emotional, physical functioning, daily activities, and sleep. And here the parents have to ask in these 7 points Likert if there is any worsening, no clear change, or any improvement. And this is very easy, and I think it could give us a lot of information. So I will end that with this slide to summarize my talk. So I tried to expose that the assessment of the severely impaired patient with rare epilepsy syndrome is a challenge for us. A comprehensive neuropsychological assessment is always needed. Test, what we really understand with test, is less than 25% of the necessary information for a comprehensive assessment, because many times, like the medical team only look at the results of tests, and this is a small piece of the whole picture. Information from family and schools and nurses is very important. The clinical observation is based on the known developmental stages. Standard scores compare the children with a normal sample, which does not give us many information, because in the evolution of these kids, the standard score always decline, always. So the raw scores are the ones that allow to compare with oneself. And that's my talk. Grazie mille.
Thank you very much, Anna, for that great presentation. It's a very, very challenging patient population that you work with, so congratulations. Any questions from the audience? It's really hard to see with these lights, but okay, well, I have a question. So I totally get your point about the importance of the raw score analysis, and when I do that, then I find myself puzzling over how much of this change would there have been anyway, even if there wasn't this new treatment? You see a change in 6 points, how much would you have seen if there wasn't the treatment? How do you deal with that kind of questions, particularly when you're speaking to your neurology or neurosurgery colleagues?
Yeah, I guess I have the same trouble as you, which is really like from natural evolution, or it's due to the new treatment the kid received? This is one nice question. I don't know. You know, and the other side is the clinical significance of those 2 or 3 points. It's really important, or from a clinical point of view. I don't know.
Well, I'm glad I'm not the only one who gets stuck on these things. But it seems to me when you talk about clinical importance, I'm always impressed when I see changes that I think are maybe really small, but parents get very excited about them. And I think that that's what's also very clinically important.
Yeah. Another point is like some parents, they tell us, no, that I feel that my kid is more connected, you know? And the neurologists just say, okay, but how can you measure that? We have no measure, no? I don't know if you use any test or if you can measure that, but it's like magic. I don't know, it's not.
Yeah. I'm not aware of any tests clinically. I mean, certainly there are research approaches that sort of look at eye gaze and interaction, but these are very lengthy and they take videotaping and all kinds of analysis, which we usually don't have time for in our clinical lives.
Yeah, that's true.
Any other comments? Thank you, Anna.
Thank you.
Oh, yeah, we do have one question or comment here. Yes. Thank you.
Okay. The developmental trajectory of early operated children is being studied. Like surgery in adulthood, surgery in developmental age is still a salient event of procedure that occurs during a delicate phase of specialization of neuropsychological function. The collaboration of the child could be not obvious. In epilepsy syndrome, there is a higher prevalence of many comorbidities and neurodevelopmental disorders implicated, like autism spectrum disorder, ADHD, and intellectual disability. Neuropsychological assessment in developmental age is a methodological issue. We must switch most tools due to the normative data. Finally, cognitive development is an outcome measure of a comprehensive evaluation, but in some conditions, it could be more important for the family to make gains in quality of life, such as behavioral regulation or performance of activity daily of life. Neuropsychology in epilepsy surgery is a model on how to follow children in a systematic way, especially during developmental age. Cinzia Correale is a clinical psychologist, expert researcher of Bambino Gesù Children's Hospital, and she has been working in the epilepsy unit since 2020 in our team. She has collaborated in multi-center projects and with the National Health Institute of Italy. I want to thank also Timothy Enger of the University of Kentucky College of Medicine, who is unlucky not here today, for the contribution to the next presentation. Please welcome Cinzia. She will present cognitive outcome of preschool children after epilepsy surgery.
So first of all, thank you so much for having me today. I'm really excited to share this session with all the colleagues, Professor Mario Smith, Dr. Simona Cappelletti. I first declare I have no conflict of interest on this session, and I'm speaking about cognitive outcome of preschool children after epilepsy surgery, which was partially introduced by Professor Mary Smith. So I chose this figure to represent because it represents a model of care of epilepsy surgery. It is not only for children, it's also for adults, but it outlines in a very clear way how the neuropsychological approach is always present in all the candidate journey or process during the epilepsy surgery. So as you can see, the neuropsychological approach is always present on the preoperative phase, but also on the post-operative phase. And it's also how can I say, one of the approaches that the patient undergoes during the multidisciplinary evaluation for choose if a candidate is adequate or not to go to under the surgery. So as of course all of you know, this is the document that better represents what indication and expectation for neuropsychological assessment in epilepsy surgery are, both in children and adults, and what are the domains which must be assessed as mandatory, of what we should really do if we have enough time in our clinical practice. So of course in children, baseline assessment, it's really important because to have a comprehensive evaluation of all the developmental profile is essential in order to understand what the post-surgery trajectories may be, and to have predictors and outcomes of assessment of the surgery. So speaking about development, epilepsy surgery, particularly when performed in early childhood, is an effective way to prevent the disease progression. As Anna said, development in epileptic children is usually characterized by a slow path, which is never really close to the normal development, and sometime after the start of the epilepsy, it declines. So surgery, it's a very effective way to promote the cognitive recovery, and we now know that the earlier the better. So strong predictive factors for favorable seizure outcomes following surgery are, of course, premorbid cognition, and we know that in very young children, usually global delays are present and are common. The epilepsy duration, we know that the shorter is the interval between the start of the epilepsy and the surgery procedure, the better will be the outcome. The age at a seizure onset, because we know that the earlier is the onset, unfortunately, the harder will be their cognition situation globally. And it's also very important to know the etiology, the extent, and the complexity of lesions. If it's, a genetic one, if it's a functional, structural one, or if it's both of them. So we can have also some, informations on what we should expect after surgery. The timing also of the intervention, it's very important for all the reasons we say before, and we need to know also the comorbidities were usually present in our patients, because usually they are underlying conditions then after the surgery may be more evident. So of course the primary aim of surgery is to have seizure freedom and discontinuation of anti-seizure medication, which is usually happening on the 70% more or less of our patients. But then, of course, after this, a very important goal is to have the recovery of developmental trajectories. So in the better of the ways, we will see stabilization of developmental function, and we were always hoping to have also a catch-up of their trajectory or an improvement as well. But as we saw, say before, surgery may exacerbate neuropsychological comorbidities who were not so evident during infancy, but this is the reason why long-term follow-up is very important to observe and document them. So I here report a study of Roulette and Perez published in 2010 in epilepsy, where they study the cognitive recovery and reorganization of plasticity of a patient, very young patients. They had a sample of 11 children who has a median epilepsy onset of 7.5 months and who performed surgery before the age of 6 years. What they found is that the longer-term follow-up shows stabilization of cognitive levels in the impaired range in most of children and slow progress up to borderline level in 2 of them with initial gains. So what they conclude is that cessation of epileptic activity after early surgery can be followed by substantial cognitive gains, but of course not in all children. And this is the ratio we have to, in order to conduct our newly published study. Where we studied children who underwent to surgery before the age of 5. We analyzed 80 children who has this procedure, but include in our study only those who were able to complete the assessment, the neuropsychological assessment, both before and after the surgery. So our final sample contained 27 children with a mean onset of 1.2 years old, with mean age at surgery of 2.9 years. The majority of our patients, so this 67% of them, had improved or stabilized developmental or intellectual function, and we included those patients, we named those patients group 1 with early age, they were youngest, so a mean age at surgery of 2.6 years, and then another group which is the 33% of our patients who has developmental or intellectual decline. We call them group 2. They had a later surgery, so their mean age at surgery was 3.4 years. What we saw is that group 1, those who improved developmental or cognitive function, had a lower preoperative DQ or IQ total score rather than group 2, who has median DQ IQ respectively was 82 versus 108. And we had a quite long neuropsychological follow-ups, who was 4 years. And the post-surgical seizure outcome for the majority of our patients was seizure and drug-free. So our findings show that in the group who gained the most performance scores were the domain that had the higher beneficial from the surgery, while in those who have declined, verbal scores and total scores were the ones statistically significantly affected. So we conclude with this discussion saying that cognitive impairment is quite common in patients with epilepsy, especially in those with early or very early onset, drug-resistant seizures and extensive malformation of cortical development, that patients with lower presurgical median DQ or IQ get the better score gains, and that was already documented in the literature, supporting the assumption that presurgical DQ IQ is inversely correlated with post-surgical DQ IQ. That the greatest cognitive loss is seen in the youngest, and this is surely because early onset epilepsy are typically severe and can lead to developmental and epileptic encephalopathies or developmental encephalopathies, as a recent review of Stefanov Yakub stated. And that most patients with drug-resistant epilepsy operated before the age of 5 had stability or improvement in developmental and intellectual domain, but of course not all of them again. The limitations of our study is that we had a small sample size, a lack of control group, and heterogeneity of etiologies and histopathologic findings. And this is a methodological issue. We have the combination of developmental and cognitive scores. So those underlines the challenges in the preschool evaluation. We think that the first of them is to obtain the cooperation and the availability of the children, which must be emotional but also behavioral. And when we have comorbidities, that can be such a rough point, and I would like to add that it is not only the cooperation and availability of the children, but also of their families. Sometimes the family have very high levels of burden of care, and undergoing under a neuropsychological evaluation is just like one stressor more, so they are not cooperating every time. So another challenge in preschool evaluation is that early epilepsy onset always is usually combined with a severe impairment. And so, as Anna said, to perform an evaluation is sometimes hard. Then we need to perform a long-term follow-up to see the catch-up of the trajectory. But then in very young children, we then lost the reliability of the tools we use because we first use a developmental tool for assess developmental profile, and then we need to change and switch for a cognitive one. And those instruments sometimes always do not have a very, reliable quotients, but even because they have, as we said, they are evaluating different skills among different periods of life of children. And this is more like a question I would like to pose to you. Should we screen also on a baseline routine way also symptoms for autistic syndrome disorders, because sometimes those are underlying neurodevelopmental issues that have nothing to do, maybe with the epilepsy. They're pre-existing, and sometimes the trajectory will affect it anyway. So the take-home messages I would like to give to you is that the baseline assessment prior to treatment allows for the more accurate assessment of treatment effects, so it's mandatory for all our patients. That long-term follow-ups are assistive and informative because permit to observe the real recovery of the trajectory, that developmental concern and diagnosis exist in context and are variable in severity, and that the patient-family education could be also a pre-habilitation, can help frame realistic expectations and goals. And then beyond the singular cognitive scores, that important that our neurologists ask to us, but we must consider that for families, other kind of outcomes could be more significant, like improvement in quality of life, sleep, behavior, adapting functions, and so on. So that's all. Thank you so much.
Thanks for a great presentation, and look forward to reading your hot-off-the-press publication. Any questions or comments for Cinzia? Okay. Yes.
Yes, I totally agree. Thanks. That's the reason why we underlined important to assess also all these domains of daily life and that they're important for families. So totally agree. Thank you for your comment. Okay, thank you.
Another salient topic is how we should manage a child with epilepsy in our care, who has multiple comorbidities such as emotional, cognitive, and behavioral problems. Scientific evidence is always a problem for many psychological therapies. In epilepsy, even more so, because we have many complex factors to consider, both in a cognitive and psychological nature. Colin Rayleigh works as an educational psychologist at Young Epilepsy in the UK and at Queen Sylvia's Children's Hospital in Gothenburg. His clinical work focuses on neuropsychological assessment of children with neurological conditions. His research focuses on psychosocial aspects of epilepsy, including cognitive and behavioral comorbidities. He will present psychoeducation and psychological support for children with epilepsy. What is the evidence? Please welcome.
Thank you very much, and it's a great pleasure to be given the opportunity to talk here today. Thank you very much, Simone. Here are my conflicts of interest. And I'm going the wrong way. Okay, now we're moving forward. Today I'm going to talk about, first of all, define and talk a little bit about psychiatric, and when I say psychiatric, I mean neurodevelopmental and mental health problems in children with epilepsy. It's important before we talk about intervention to sort of understand the extent of the problem and also some of the issues with psychiatric problems in children with epilepsy. And then I will talk a little bit about, what is the evidence for what might actually work in terms of psychological interventions in children with epilepsy, focusing on anxiety and depression, touching on ADHD, but actually more about executive functioning, and then focusing a little bit on broad-based emotional and behavioral problems. So there are a number of different terms here, but in general, what I'm talking about is psychiatric problems, ADHD, depression, anxiety, behavior and emotional problems. Some children will have a diagnosis of a psychiatric problem. Other children will have difficulties, but they may not have a diagnosis. But in any case, there are a lot of children who actually need our support, a lot of children with epilepsy, and I'm going to talk a little bit about how best we can support them if they have these difficulties. It's always useful to look back and always think about, when was the realization that children with epilepsy had, a lot of children with epilepsy had, psychiatric problems or difficulties with behavior and emotions. This is a classic study from 1970. Michael Rutter led the study, the famous British psychiatrist. And basically the study showed that children with epilepsy, both uncomplicated and complicated, so complicated usually meaning structural brain problems, cerebral palsy, both groups had significantly higher levels of psychiatric problems than the general pediatric population. And that was more than 50 years ago. A number of studies have followed up on that. For example, Sharon Davis in 2003 in the UK showed that rates of psychiatric disorder were 37% in epilepsy, only 11% in diabetes and 9% in controlled children. So epilepsy it stands out in terms of other chronic conditions, particularly non-neurological chronic conditions. Our own study in 2014 looked at this as well, and we found, for example, that 21% of children with epilepsy in a population-based study met the criteria for autism, 33% for ADHD, developmental coordination disorder, so motor coordination problems, 19%, and depression and anxiety were also elevated. Slightly lower than some other studies, but then we had a younger age range than many other studies in terms of depression and anxiety. What was interesting, so of the 60% who had met criteria for psychiatric disorder, only 20% had previously got a diagnosis, so only 1 in 3 had received a diagnosis, so under-recognition is a major problem. Okay, so one thing that we sometimes get asked about a lot is, what is going on here? How much is the epilepsy contributing? What's actually what in terms of these type of problems? So, the chicken and egg situation, what comes first? And I think it's important to know that sometimes many of these children have complex neurological presentations, and epilepsy may be a symptom of an underlying brain condition. And this very nice study from Jana Jones in the US in 2007 showed that many children with epilepsy actually have behavioral and emotional psychiatric problems before the onset of epilepsy. And that's particularly in the case of ADHD. And, it means that many of these children, have difficulties which are not due primarily to their epilepsy. And as I said, there is a big problem with under-recognition. 2 studies here show that, the majority of children with epilepsy actually are not getting support or are being identified in terms of their mental health or their psychiatric difficulties. One might wonder, why is that? Maybe there's an over-focus on the epilepsy, so maybe the epilepsy is overshadowing the other issues, or maybe it's a lack of resources. There are not enough psychologists, there are not enough people asking the right questions in terms of these children, asking, are these difficulties actually present? So there may be a resource issue as well. And of course, it's important to point out that these additional psychiatric difficulties in children with epilepsy, they're often more impairing than the actual epileptic seizures. They often have more of an impact on quality of life. They often contribute most to the cost of the condition. So more than the epilepsy medication, more than all the investigations, many of these children will require extra support in school. So these type of extra supports can cost a lot of money, and as I said, can cost more than the treatment for epilepsy. And we know that these type of difficulties in children with epilepsy have a very significant impact on family functioning. And we know, for example, that they're associated with parental mental health difficulties, and particularly mothers of children with epilepsy have elevated rates of depression, anxiety, and stress. One of the questions that has been addressed in terms of the presentation of these type of difficulties in epilepsy, is it somewhat different than the presentation in the general pediatric population? If we take ADHD, we find that children with epilepsy often have more problems with inattention than hyperactivity or impulsivity compared with the general population. So they may not get the combined diagnosis of ADHD. It may be more the inattentive subtype, and they also tends to be a more equal, gender or sex ratio in terms of boys and girls. Girls often have close to the same ratio or prevalence of ADHD as boys and girls are quite equal, unlike the general population where boys are much higher. In terms of autism, we know sometimes we see children in the clinic, particularly with developmental and epileptic encephalopathies, where there are periods of stagnation, periods of regression, and it's actually quite difficult to know. And sometimes we do see children developing, for example, autism at a later stage than we might expect in terms of the typical age where we would see those symptoms. So this study from Harriet Holmes at Great Ormond Street in London suggests that the phenotype of autism, particularly in early onset epilepsy, it may not follow the typical trajectory and can fluctuate. And we do sometimes see this as well, that sometimes children can appear more autistic and less autistic with time. And in terms of anxiety and depression, and again, this has been recently highlighted in a paper which is just coming out at the moment on guidelines for treating anxiety and depression. It's important to separate out ictal and non-ictal symptoms. So it's important to think about what role seizures might play in anxiety and depression. And one of the recommendations from that paper was that it's very important to actively ask if symptoms of anxiety and depression are related to seizure worsening in children and adolescents with epilepsy. Another issue which is important to say, that many of these children have symptoms or difficulties in more than one domain. I'm not always so clear that the term comorbidity is helpful, because comorbidity might imply that epilepsy is the main condition, and there might be a number of different conditions going on. It's not always clear what the main condition is, but there's certainly a high degree of co-occurrence. In our own study, we found that 26% of children had more than one psychiatric disorder. So, for example, children with autism and ADHD, children with anxiety and depression, children with anxiety and ADHD, and a similar level was found in Sophie Bennett's recent publication in the MICE study. So this can be important in terms of treatment. So what do you treat if there's so many things going on at the one time? So now to move on to the main part of my talk, which is around what can you actually treat or support with psychological intervention in pediatric epilepsy. And I'm not going to be exhaustive and go through every possible sort of difficulty or symptom, but I will focus a little bit on ADHD, again focusing more on executive functions, depression, anxiety, and then more sort of behavioral emotional problems, which may not always reach the criteria for a psychiatric disorder. So recently we've had a systematic review looking at this, looking at psychosocial interventions in pediatric epilepsy, published from the group in Glasgow. 10 studies were reported on, and they had previously looked at this about 10 years ago, and what they note is there is an increasing evidence base. This isn't an area with a lot of evidence, but there is actually more and more coming out, which is good. 4 of 10 studies were rated good quality, and the findings were promising. So what type of interventions are we talking about? So psychoeducation, so learning about the condition, cognitive behavioral therapy, and mindfulness. And in terms of goals, I think it's important to think about if we're trying to help young people with epilepsy who have these type of difficulties, what should be the goal? Better quality of life, a decrease in symptoms if they have clear psychiatric symptoms, but also helping the young people understand their condition and giving them skills which they can employ in everyday life. Okay, so talk about the evidence now in the particular conditions. We start with depression and anxiety, again, the publication which is coming out identifies that cognitive behavioral therapy is the most frequent therapy used to treat children with anxiety and depression in epilepsy. There are a number of studies, but a small number of studies in depression and anxiety. This study here comes from 2006, and it actually focused on sub-threshold depressive symptoms. It was an RCT, and it demonstrated that CBT was superior at improving depressive symptoms and preventing depressive disorder compared with psychotherapy as usual. We also have some data in terms of anxiety, and again, it's CBT, and it focuses on manual-based, computer-based CBT, and again, we see improvement in symptoms and a reduction in behavioral problems. So these are relatively small studies, so the evidence base isn't robust, but there is some evidence, and I think what we can take from this is that therapies that work for children without epilepsy will probably work for children with epilepsy. Moving on to executive function, and again, we heard earlier a little bit about what we mean by executive functioning, but it's important to say that many children with epilepsy often have problems in this area. And there is a nice study which came out in 2019, a web-based executive function intervention where the children develop problem-solving skills to address executive functioning deficits by navigating through various islands or lands. 10 learning modules focus on the core components of executive functioning, so working memory, problem solving. And again, here we have good news. Caregivers and adolescents reported improvements on the brief, which is a measure of executive functioning. And as well as that, there was also a little bit of spillover in terms of emotional behavioral functioning and health-related quality of life. So you might wonder what this particular intervention looked like. And again, these are the islands or the various lands that the children can travel through, where they focus on particular executive functionings like memory, inhibition, problem solving. So giving the children skills in these areas to help them improve everyday functioning. We also developed in our centre in Gothenburg an approach called SPACE, which is supporting attention in children with epilepsy. So we wanted basically to identify children with epilepsy who had significant attention problems, children aged between 8 and 13 years, and this was a single arm, so not randomized, no control group. In terms of the 6 sessions, the first 3 sessions took place in groups of 3 to 5 children and 2 psychologists, and the final 3 sessions involved 1 psychologist meeting the child and parents. And what was really important in this particular intervention was that the child's teacher joined for one of the final 3 sessions. So we could talk to the teachers about what we were actually doing in terms of the intervention and talk about the problems that the child was having in the classroom. And again, not very, very strong data, but some data suggesting improvements in health-related quality of life and some aspects of executive functioning. We didn't find great improvements in terms of ADHD symptoms, but I think in terms of treating ADHD in children with epilepsy, the ideal treatment will probably be medication plus psychoeducation. And again, the qualitative feedback was positive. The intervention was acceptable. And what a lot of the young people liked, and parents as well, was actually meeting other children with epilepsy. In terms of what a session might look like, so this is the first session was very much focused on psychoeducation. So actually trying to help the children understand what is attention, what is concentration, what is focus. So we looked at films, we did various activities. And this is really important because sometimes children have difficulties actually explaining their difficulties or putting words on it. And it can be very helpful actually understanding what the difficulty is, and therefore it's a starting point in terms of developing goals to improve everyday life at home and at school. The final study I'm going to talk about is called MICE, Mental Health in Children with Epilepsy, and it is integrating mental health into epilepsy clinics. And what is interesting about this is that it focuses on what I talked about earlier, that co-occurrence, that many children with epilepsy have symptoms across multiple domains, and it's important therefore to think about what actually do we want to treat here? What are we going to prioritize? So it's a multi-centre, open-label, randomised control trial in England and Northern Ireland for children who met diagnostic criteria for a common mental health disorder. So that was things like depression, anxiety, or behavioural difficulties, or disruptive behaviour. And the approaches used were evidence-based, the manualised approach using cognitive behavioural therapy and behavioural parenting strategies. And the primary outcome was the Strength and Difficulties Questionnaire at 6 months post-randomization. And, I was involved in this study. It was led by Sophie Bennett. And what was interesting was that, the majority of interventions for children with epilepsy actually were behavioral interventions, so parent training strategies, not so much depression and anxiety, but strategies which I'll talk about in a second that most of you will be very familiar with and very, are very easy to implement. Just talking about the results of the trial, what you can see here is that basically the SDQ score improved for the MICE group, so the intervention group at 6 months. Interestingly, it also improved for the control group. So the SDQ score was also improved by not as great an amount as the intervention group. So one might wonder what's going on in the control group. Why are they getting better as well? Well, one of the reasons might be that the control group also underwent assessment. So even assessing children and providing feedback on their difficulties actually might lead to a greater level of understanding. Those children got what we call treatment as usual. So it's not clear what treatment they had got, but many children with epilepsy don't get any treatment for their mental health problems, even if they are diagnosed. But there was an improvement in overall functioning for both groups, but the improvement was greater for the intervention group. So really good management of these difficulties in children with epilepsy actually starts with good assessment. It's really important to identify the difficulties, explain to the child and the parent what the difficulties are, and that actually can be a great starting point in terms of improving quality of life and improving those difficulties. It's important to say also in this study that the improvement in the children was not just in children, normal cognitive functioning. There was children with intellectual disability in the trial, and also children with autism in the trial. And all of the subgroups improved in terms of SDQ scores, so their emotional and behavioral functioning improved. And again, this is, what I was talking about in terms of very simple parenting strategies, which the mice study included. One-to-one time or special time with a parent. So saying to parents that, you can spend a small amount of time playing with your child and giving them, attention. Simple praise, being very specific about that praise. Active ignoring, so ignoring behavior which is not wanted, or which is challenging in terms of the parent. And obviously a lot of the debate we had in terms of when we were actually implementing this was what can you ignore and what you cannot ignore. So there are some restrictions there, but having a discussion with parents and saying actually how impairing is this particular behavior, maybe you should ignore it, maybe it is seeking attention, and maybe when the child gets better attention for doing something positive, they will then realize that the other behavior was not going to give them what they wanted. And also, using rewards, individualizing rewards for that particular child, identifying their interests and actually using reward charts. So there's nothing really new in this approach, but it was, it was successful, and there is evidence that this works in children with epilepsy and behavioral problems. Okay, so what can psychology offer in terms of children with epilepsy who have these type of difficulties? What is there, available? And as I said, good assessment is the start of treatment. So really important to identify these difficulties. Resources are scarce, but it is really important that these children are screened for these difficulties. There is positively an expanding evidence base for psychotherapy and psychoeducation across the spectrum of psychiatric difficulties in children with epilepsy. So depression, anxiety, behavioral difficulties, executive functioning difficulties. I haven't mentioned autism here because there isn't really an evidence base, and I think the question is, should you be treating autism or should you be treating the difficulties which might arise from autism? And I think that's a question which some of you might have views on. Many children with epilepsy have difficulties across multiple domains, and therefore it's important to prioritize and set goals with parents and the young person. What can we work with? What do you want to focus on? We may not be able to focus on everything here, but if we focus on some things and they improve, quality of life improvements will also come with that. It's important to say that for some children with epilepsy who have a diagnosed psychiatric condition such as ADHD, depression, anxiety, pharmacological interventions may also be needed, but it's important, I think, to combine those with psychological interventions. And obviously, it's always important to try, for the child with epilepsy and holistic care, to try and optimize seizure treatment. That may not mean seizure freedom, but it's important to have that conversation between the psychologist and the neurologist, or the psychiatrist and the neurologist, to try and achieve what is the best case scenario here in terms of minimizing, side effects and maximizing seizure control. And it's not always that easy, obviously, to do that. So there are, there is an increasing evidence base, but there are also very significant gaps. This is not an area where there are a lot of studies. The mice study has come out this year, and I really think it set the standard in terms of being a randomized controlled trial, being a fully powered trial. But we do need more high quality studies here. I think there's a need particularly to focus on young children and children with developmental and epileptic encephalopathies. So these children who seem to, stagnate or even lose skills or develop behavioral difficulties quite quickly, and often quite significant behavioral difficulties very early on, and parents often struggle greatly, to manage those. And it's very important to think about, there are a number of new, treatments on the horizon here. And I think it's very important that these new treatments in terms of medication, possibly genetic therapies, that psychology can also offer support perhaps to buttress those new treatments in terms of the child's outcomes. So there will be a role for psychology, even if these new treatments are primarily focused on, you know, treating the seizure or treating the underlying condition. I think we also can offer a lot in terms of, you know, evaluating those treatments, but possibly also in terms of interventions, and possibly there can be an additive effect with the new treatments and psychology interventions together. Thank you very much for your time.
Thank you, Colin. That was great. Any questions or comments for Colin or for any of the speakers? Yes. Oh, could you come to the mic here so everyone can hear you, please? Thank you.
Thank you very much for this talk and also the other talks. Related to the point that you say about the gaps we have still in learning about which interventions will work, we could set up many clinical trials. What is your opinion of using metadata from clinical data? Because there are a lot of data already in our systems, and if we would collect them in a systematic manner, so standardized outcome measures and patient-related outcome measures, could we move a little bit more from clinical trials to using more real-world data? I'm curious.
I think a lot depends on the quality of that data with regard to if there is psychological support or intervention being provided. So if we can track psychological interventions, if children have received psychological support and what that support might be, I think that's possible. I think the question will be how to actually describe that or how to actually include that. You know, so but I do think it's possible. But we need to think about, you know, how we actually record that data. And I think we will have better data on maybe disease aspects, on epilepsy or seizure treatments than we will have on psychological therapy. But it's certainly something I think which moving forward we should think about, because I think there are opportunities with big data and there are opportunities with, you know, AI. Thank you.
Well, I'd like to thank all our speakers and to thank the audience for your interest.